Hello. Thank you, Hala. Thank you for the invitation. So, can you see my presentation? Okay. So I was supposed to talk about rehabilitation, and Ala asked me to talk about blast injuries, specificities, or amputees after blast injuries. But after a little bit of experience, I think that's better to talk about how to enable basic amputees needs. Because right now, the basic needs are not met. So I will be short and really quick because there is a lot of small things that we have to discuss about. But basically, for the amputee care, you need assessment and follow-up. This is central. All prostheses will need to be reviewed and adjust. You can have, we talk about with Dr. Youssef, but volume changes, neuroma, friction, you can have problem with alignment, etc., and everything can lead to prosthesis abandonment. So one of my work this past year was the remote assessment. I developed tools specifically for blast injured patients, and I tried to develop a trust relation with my patients because we have a big problem with patients from Gaza. They are afraid to and to say that the components they are not using the components and so on. So we had with the team we had a systematic approach, and we discovered several issues in Gaza and outside Gaza. So in Gaza, the first step of my job is to know if the patient is ready to fit or no, and sometimes patients will need some physical therapy, surgery, specific medication. Why? Because I cannot send my patient to the CPO facility. First, because that's not easy to circulate inside Gaza, and you don't have enough CPOs, and you cannot take their time with a patient that is not ready to fit. So what is needed inside Gaza to meet this objective? I will take some example. For example, this patient is a 21-year-old. He was shelled by a tank in his two legs. He was amputated on the left side below knee. He had several fractures on the right side and had a external fixator for several months. So he didn't walk for several months. And he was referred for force-fitting, and he declared no pain and no previous fitting. So we asked him to go to the near facility. We told him then that he already has a prosthesis that was too heavy for him. He declared near 4 kilos. So we asked the company that was sending the components, is it possible, what type of components? Then TPO that fits him tell her that he was too weak to have a prosthesis and that he needs physiotherapy, and that he says so to the patient. And in the end, we sent a physiotherapist to have a complete assessment and to have an assessment, including for the contralateral leg. This is him with the physiotherapist, and you can see that he's complaining about the socket, but in reality, so he's complaining about the socket. But in reality, if you look at it, he's not able to put weight on his prosthesis. So adjust the socket here is not a big deal with the technology from the Jordanian. The real problem is here. You can see his reaction to pressure. So basically, this patient has been fitted, and then the next day he began to have a neuropathic pain that was growing, and has an history that is typical for neuroma. So this patient, I cannot send him to a CPO center. I need to send him first to a neurosurgeon to be evaluated and maybe to have a surgery. Another patient is this patient. His left above knee amputation, And through the amputation, they discovered that he has diabetes, and right now he has persistent ulcers. The ulcers are chronic, and he's not, and I think because he has chronic ulcers, he has diabetes that is not balanced, and because the diabetes is not balanced, he has persistent ulcer. He don't have follow-up for it. And he has severe phantom pain. The volunteer that was talking with the family was hearing the patient screaming on the background, and he has hip retraction. So you can see his maximum hip extension here. This is his maximum active hip extension. So this patient needs physiotherapy for his hip retraction. He needs medication and motor therapy for his phantom limb pain, and he needs a follow-up for his diabetes. He's not ready to fit, and we need to take care of all these issues before sending him to the CPO center. I just want to share to you the algorithm of 2022 for the phantom limb pain, how to treat it. That's not complicated, but sometimes it can be hard and complex. Usually that's the job of the physiatrist, so the physician specialized in physical and rehabilitation medicine. And so you can see what is we need several services inside Gaza to treat the phantom limb pain. So what we need with CPOs and inside Gaza, we need some basic services. So neurosurgery, we need specific medication for the neuropathic pain. We need specialized therapists in motor therapy and so on. We need crutches and wheelchair. The first patient don't have crutches, so we can send him to the neurosurgery consultation, but he don't have crutches to go. And as well, we don't have, it's really hard to have a transportation service inside Gaza. So this is really important to have these two services that are available. So crutches, wheelchair, and transportation service, so the patient can go to the hospital and this CPO center. Outside Gaza, we were a little bit surprised. I just want to mention that this is the responsibility of the CPO center to set appointment and follow-up appointment for the patients. And this is the responsibility of the NGO that is paying the CPO center to control that they're doing this work. Basically, we had to go with Dr. Youssef visit our patient because we didn't have satisfying answers. And we discovered that there is, for most cases, no follow-up. And because there is no follow-up, the patient ends up with several prostheses. So basically, our goal is rehabilitation, but that's not possible because, for example, the patient will have his first fitting, he then will have volume changes, friction. He just needs small adjustment. But because there is no follow-up, the patient that has no knowledge on prosthesis will think, okay, I have pain, I need a new prosthesis. He won't think that he needs just adjustment. And plus, if the CPO center is not giving him a new appointment, he will go to another piano facility. And because there is no data and there is, I'm sorry to say that there is NGO that will give the money without controlling anything. He will have a new fitting, then a pain, volume change, and so on. So the problem with that is that, for example, when you are an NGO that want to control what is going on, a CPO center is able to say to you that if you don't pay, other NGOs will. So we have lots of of issue with that. For example, we see patient previously. So this is a Pirogov left amputation. This is a long amputation. The patient has already toe amputation on the right side. She has muscle calf defect and soft tissue defect, and she has a fracture of the left knee. This patient was, we pay for prosthesis, and after that she get fitted with the prosthesis, she fell on her knee and she had a new surgery. So this is after the new surgery, this picture. And for the additional needs, she needs physiotherapy because she has a stiff knee, and for her scar tissue, she's followed by a orthopedic surgeon that is doing hyaluronic acid and mannitol injection that are expensive. So it's near to $200. That's huge for a refugee. And this is the patient for her first. You can see that's not satisfying. And this is the same patient 3 months later. And you can see that she's still limping. And on the phone, she's complaining about her knee. She never complained about her prosthesis. So when we saw her, she had this prosthesis that is not what we paid for. She got a first prosthesis at a physio center that was not adapted. Then we give her another prosthesis, but because of the knee surgery and the conflict, again, the knee, she abandoned her second prosthesis. Then a big NGO go at her home and give her this prosthesis that is not adapted to. The surprise was that everybody was giving her prosthesis, but she has neuropathic pain at the light touch, and she needs a surgical revision for the nerve and the shape and the length of her stump. And for the knee, she didn't need expensive infiltration. She just need some scar massages. So this patient ended up with several prostheses and was needing a surgery. So why is it concerning for the patients? Right now, the majority of prostheses are not usable. Because of this system, you have CPO centers that don't give patient control appointment. There is risk of complication, and the whole system is disabling the basic amputee care. Why is it concerning on a human level? It is unmasking unethical practices. We can see competition between NGOs rather than collaboration for the patients and to be respectful to the donators. There is human exploitation, so numbers over quality, picture exploitation, the possibility for a center to use multiple donation for the same patient because there is no control. There is a disregard for the future of the patient because the same money is not used for better component or for the right surgery. It's not safe for later. So who's going to pay for the new prosthesis in 4 or 5 years? It's not used for school training because all these patients need education and professional retraining. A construction worker that lose his leg will needs education to learn a new skills, has diploma and became financially independent in the future. And this money is not used to prevent perfectly non-long-term complication. So we know what type of complication will be associated with their amputation. For example, we know that they will have overuse syndrome, low back pain in the first year, more if they don't have follow-up. They will develop metabolic disease. And we know that in the future, they will have 7 to 10 times more risk to be amputated on the other side. And all of this is preventable with some models. So what are the solutions? We need centralization of data, and we need to control the delivery services by specialists, people that understand what is needed. We need to review non-satisfied cases by multidisciplinary team specialized in rehabilitation. We need to raise awareness with education program for the patient. We need to develop amputee care program based on proved successful models that are existing and are working for long-term management. And I have to speak about that, but we have to stop the colonialist mindset. So what I want to say about that is that everybody is coming with solution for Palestinians, and nobody is asking the Palestinians. So they come with solutions in their mind. They think that can work, but the reality on the ground is completely different. And nobody is asking the Gazan, what do you need? So they use the money of the Palestinians. Finally, it's the money of the Palestinian, and are doing unrealistic projects. This is a big issue. And just to finish, I just want to share to you just what we need in rehabilitation for the patient, and how people that are working with this patient how they are thinking. So this patient, it's a patient that I have in Switzerland. You can see this is a nice room. The ground is adapted for a wheelchair. He's a paraplegic, and he's learning how to do transfer. So he has an aid. He has a transfer plank. The height of the bed is adapted. And little by little, he will learn how to do his transfer and to be independent, and to be at home. This is the same process for the kitchen, for the bathroom, and so on. So you need to adapt the environment first for all disabled patients and to train them. I have a colleague that has a heated argument with the director of a big NGO that was arguing that the patients from Gaza don't need correct accommodation, and that they just can be intense. So this is the people that are taking care of them, and we have to be careful. And this is why this is my conclusion. We have to be careful and don't be colonialist, and we have to use specialists that understand why we need such a adapted environment, why we need psychologists, and why we need this type of medication, and so on. So, voilà. Thank you very much.